Okay, I guess we'll get started. We're not at critical mass, but we are close. Well, not close, but we are close to 100 people, and so I think people will trickle in as we're going through the panel. So I just want to say welcome, everyone. Happy Wednesday, and thank you for joining us on this webinar, how to keep young people safe through mobile response. I want to start by introducing myself. My name is Whitney Bunce. I am a policy analyst with the Center for Law and Social Policy, a national nonprofit, nonpartisan organization that work on anti-poverty solutions for low-income people around the nation. I will be your moderator for this event, and this event is recorded, so if you have to leave early, we will be sending a recording afterwards, and we'll follow up with some resources. So now that you know who I am, I want to know who all is attending this event today. We're going to start off with a poll. So Kayla, can you pull up the first poll? So we just want to know who you are, who's joining us today. Are you an advocate? Are you a young person, an educator, a state agency official, or a health staffer? If you're other, also say that, and then you can also drop, if you're other, put who you are in the chat, where you're coming from, and who you're representing. And then the second one is, how familiar are you with mobile response? We just want to level set to see how knowledgeable our attendees are about mobile response. We know that people come with different levels of knowledge, but we want to ensure that we are given the most accurate and adequate information so that you all can be on this learning journey with us as we go through the panel. So as I'm looking at the poll results, we have a range of people in the audience, and it looks like we have about 27 advocates, or 31% of the people here are advocates. We have some young people here. We have some educators. We have state agency officials. We have some other people in there introducing themselves in the chat. We are so happy for all of you all to be here. We're excited to learn with you and from you. And so our next poll, people already started answering. How familiar are you with mobile response in crisis? There's some people who are very familiar with mobile response, some people that are somewhat familiar, and then there's a little familiar and not familiar at all. And all of these are amazing, because I think we are all going to learn a lot today from our amazing panel. I'm so glad that you all are joining us today to learn with us and from us, and we're happy to learn with y'all and from y'all. And feel free to ask any questions that you may have. Questions and answers will be at the end of the event, but if you have any questions as people are talking or as our panel is talking, please drop them in the Q&A section of the webinar or of the Zoom. Is right at the bottom of your little tabs at the bottom, and say Q&A and then share screen or more. I'm not sure what it looks like on the participant section, but I think it's just like 3 of the different tabs that you might have on your thing. So for the people who aren't as familiar with mobile response, we are excited that you're here, as much as we're excited about the people who might be very familiar. Like I said, this is going to be a great learning experience for everyone. And even if you're not familiar, we have some resources that we will be providing y'all, including my report that I just released back in April, Youth Mobile Response, an investment to decriminalize mental health. One of my colleagues will drop that link in the chat, and you all can use that as a resource to learn more throughout this event and after. The report centers Black and Brown youth with a mental health crisis and providing alternative to law enforcement and the criminal justice system being their access point to mental health supports. In this report, we provide states and locality with 6 critical principles for mobile response implementation. However, we try to emphasize the harmful impacts of co-responder models. If you're not familiar with co-responder models are mental health providers responding to a crisis with police officers. We do not advocate for co-responder models. We believe that mental health professionals have the knowledge and the expertise to respond by themselves to crisis calls. Additionally, we explain why the usage of 988 isn't only a good idea, but vital for Black and Brown youth. If you all are not familiar with 988, it is a new legislation that was just passed last year under the National Designation Suicide Hotline Act, which basically creates a national hotline number for crisis calls. And right now, many state advocates as well as officials are creating legislation in their states to make 988 dispatch specifically for mobile response, including the crisis call. And so people will nationally in July or June of 2022 will have access to this number 988, where they will not have to use 911 to get access to mental health supports and crisis help. And then we highlight three different models around the country. Connecticut, which we have someone from Connecticut here today. Oklahoma, we also have someone from Oklahoma today. And then we talk about Cahoots. These places are not perfect, but we offer great insights, they offer great insights and best practices for other mobile response units across the country. And then lastly, we explain different funding models. We learned through this report that many people, mobile response units are not sustainable through their because of funding mechanisms, but we provide different ways that people can fund their mobile crisis through Medicaid as well as through waivers, and then how the federal government can improve federal or funding through federal mechanisms, including passing some different legislation like the Cahoots Act. So during this webinar, we will not be focusing directly on the report. So that's why I just wanted to provide you all with an overview. But we will, kind of talk about some of the critical elements of the report. We will use this webinar as a way to have a conversation with the practitioners and young people and researchers on the ground that's doing this work in mobile response systems, to deepen our understanding of mobile response and the positive impacts that it can have for young people of color and communities of color overall. We will begin visioning what it will look like to have a police-free mental health. And that is our goal, and how 988, the new national hotline, can play a role in ensuring mobile response is safe and equitable for young people of color and communities of color overall. And then we will conclude with questions and answers from the audience. And then we will have the participants, give the participants a call to action. So I hope you all are excited about this event as much as I am. I've sat with these people on different calls and been in conversation with them, and I feel like they have a lot to offer, and I hope you learn just as much from them as I have. So finally, as I said, if you have any questions throughout the webinar, put them in the Q&A. But no further ado, let's introduce our panelists who is here with us today. We are joined by Geneva Strech, who is from Oklahoma. We have Smitha and Dr. Jeana from Connecticut. So we're just gonna have, I don't like doing introductions, but because I feel like panelists can do a better job of introducing themselves. So Geneva, if you could introduce yourself, your name, your location, what you do, and what you're hoping to tell people about mobile response today.
Hello, everyone. My name is Geneva Strech. I am the Associate Director of the E-Team at the University of Oklahoma. We're a research and evaluation unit, and we have been the Oklahoma Systems of Care evaluators since 2002. I always like to tell everybody I started right out of kindergarten. We have seen systems of care grow across the state. We have used data to build the system, the mobile response system. And that's what I'd like to share with everyone today. The way that we've been able to do that is to really put data to use to convince people to fund it and support it.
Thank you, Geneva. Smitha, if you could introduce yourself and tell people what you're excited about telling about mobile response today.
Hi, yeah, my name is Smitha Gundavajhala. My pronouns are she, her, and hers. I'm a change maker with the New Deal for Youth project through the Center for Law and Social Policy, and I'm also currently a student at the University of Washington School of Law. My whole life have been doing what feels like mental health advocacy work. When I say my whole life, I mean I started in college because that's when I was diagnosed with, my own mental health. And I just kind of realized that the systems that we have in place aren't really equipped to respond to young people. And oftentimes the systems that we have in place for adult mental health response don't consider the unique needs of young people. So I'm really excited to talk about how youth mobile crisis can be more responsive to the needs of young people specifically.
Thank you, Smitha. And Dr. Jeana, can you tell us your name, your location, and what you're excited to share with the audience today about mobile response?
Yes, absolutely. Thank you for the invitation to participate with you today. I'm Jeana Bracey. I'm the Associate Vice President for School and Community Initiatives at the Child Health and Development Institute in Connecticut. And our role in terms of our statewide mobile crisis program is that we run the statewide performance improvement center here at CHDI. And so what that means is we collect all of the statewide data around how the mobile crisis system operates and in terms of mobility and response and reach across our state to all the students and children. One of the things I'm particularly interested in sharing with you today is about another program that we coordinate, the School-Based Diversion Initiative here in Connecticut that we co-developed, and it works really closely with mobile crisis to help divert youth from the juvenile justice system, particularly by having mobile crisis be responsive in times of behavioral health challenges directly to the school. And so I think that's really a unique component of our state kind of array and how we use our mobile crisis program. So thank you again for having me here today.
Yes, of course. Thank you all. So our first question for the panel today, and I'll go back to Geneva, is to just tell us a little bit about your mobile response unit in Oklahoma and how it works and some of the positive impacts it's had in your community.
So across Oklahoma, we designed a system with a localized call center. We partnered with the suicide prevention call center that was already in effect. They already had infrastructure in place, and it allowed us to get going quickly. And then we partnered with our systems of care providers in 77 counties to provide mobile response teams. And we built the mobile response teams through systems of care staff. So mobile response teams go out with care coordinators and family support providers. Those care coordinators and family support providers have access to clinicians if the crisis situation escalates to that. But the primary mission when they go out is to de-escalate the situation, to stabilize the youth in the community, connect with outpatient services. As a part of that, we actually we built a respite system that actually has funding behind it, where we offer to connect parents with respite situations. Sometimes it's a place where a youth can go for a weekend. Sometimes it's a more sustained respite where we actually have some respite situations where kids are going to dance classes or even Taekwondo classes twice a week, just to give everybody a breather. The respite program has been very successful. We go into the schools. We actually go into the schools. And so when we're looking at our two biggest measures of success are placement stability and also school stability. We had found that a lot of the crisis situations that were happening at schools were just jumping to expulsions and suspensions, detentions, those kinds of things. And so right now, we have a 90% success rate of getting the kids, the young people back into the classroom. We're going in actually at the school location, and we're de-escalating the situation there. We're still connecting the students and then the family with services, but we're also doing some training and technical assistance with the schools so that they understand a crisis situation and can, kind of recognize it before it gets to be at a crisis situation. We've done some stakeholder engagement with teachers and learned that teachers report that they don't feel they get enough training in how to recognize when a situation is going bad before it gets really bad. And they also feel, or the responses that we've gotten, teachers didn't understand how some trauma and behavioral health issues can impact the classroom. I had one teacher tell me I had to learn it wasn't about me. The response wasn't about me. So I think those have been very successful. Our diversion rate right now, meaning diversion from change in placement, is 79% across the state. And then we have a 90% diversion rate from being diverted out of school. We look at a lot of other things, but those are the two big things that people really look at. We're also looking at cost savings, where we are looking at, can we keep most of the crisis clients out of inpatient, because that's the most expensive thing, right? 82% of our young people who do experience a change in placement are going into inpatient hospitalization. The rest of them are changing they're changing foster homes. They're going to a different custodial situation. They'll move from, one custodial parent to another custodial parent, those kinds of things. And we're concerned about stability in schooling and stability in services, bouncing back and forth between therapists in different cities, those kinds of things. So our primary focus is stability. And those are the numbers and the data that we take to the Oklahoma State Legislature. And that's the way that we've been able to grow and sustain, for so long. Systems of Care submitted to do this mobile response through SAMHSA funding, and that funding ended, and we were able to continue funding with Medicaid dollars and state dollars. Oklahoma was successful in getting Medicaid billing codes, and so all of our teams can bill. Even there's a family support Medicaid billing code for Oklahoma. I feel like I'm just talking a lot, so you guys let me know.
No, you're fine. And I think you're starting to get into some of the other questions, but we'll come back to this billing stuff when we get to that question. Dr. Bracey, if you could tell us about your mobile response in Connecticut and some of the positive outcomes that you have seen.
Sure, absolutely. As I mentioned, our mobile crisis system is a statewide system, and it's managed by our State Department of Children and Families. It's available at no cost to children in the state, to all children in the state, but it is reimbursable to Medicaid and private insurance providers. And I know we'll talk more about the funding piece later. But our program is very similar to the model Geneva was just mentioning. And I know our states have collaborated on some of these presentations previously around the work that's happening, but we do have a centralized call center. So all of the calls come in through 211. That's the only number you need to dial in our state to be warm handoff transferred to one of the 6 local providers that covers the whole state. One of the features of our system is that crisis is defined by the caller. So there are no strict limitations in terms of what types of calls can come into the system. So all the calls are triaged and provided with support. All the staff that respond to mobile crisis calls are licensed or license eligible clinicians. And as I mentioned, our role at the Child Health and Development Institute is as the statewide performance improvement center. And so that came about after our statewide system was re-procured back in 2008, 2009. And so we collect all the statewide data around tracking referrals, tracking response time, tracking outcomes to really make sure that the system is running smoothly, with fidelity and with quality. We also, as I mentioned, had served as the statewide coordinating center for the Connecticut School-Based Diversion Initiative. And that's a model that we co-developed with our state partners about a little over 10 years ago. And it relies heavily on this mobile crisis system to really divert youth with behavioral health needs from juvenile justice involvement or police law enforcement involvement in the schools by having mobile crisis respond directly on site to school-based incidents as well. And so with that relationship, we've really seen a great response to students and to young people. And in fact, just before, prior to COVID, schools were the highest referral source to our statewide mobile crisis program, with families being second, and then the emergency departments being kind of third, but significantly lower than those two. And again, as was mentioned previously, the real priority of this is to divert youth from police juvenile justice involvement, as well as emergency department involvement. So in terms of some of the outcomes, some of the successes, I mean, we've really seen tremendous growth in utilization of this system over time. We took a little dip, of course, during COVID, but those numbers are certainly starting to come back up as well. So prior to COVID, we're averaging about 12,000 episodes of care per year, serving over 11,000 children in the fiscal year 19. And our highest point, it was about over 20,000 episodes of care in a year. And so, Connecticut's a pretty small state, so that's pretty significant in terms of how many youth are being served by this program. We also have a 90% mobility rate that our providers are held to as a benchmark, as a standard, and we consistently exceed that benchmark. Most recently, about 93% being the average, that 93% of the calls have a mobile response. The other options are it can be handled just sort of on the phone only, particularly if they just need information or a phone number or contact information, things like that. We also have a deferred mobile response option where the caller can call in, and for whatever reason it may be determined that you don't need to respond on site directly at the moment, but maybe it's best not to have the response happen at the school. Maybe you need to wait until the parent's able to get home and let's do the response at home, for example. So there is a deferred mobile option as well. We also have a 45-minute response time benchmark. And so 80% of the time they're expected to respond on site within 45 minutes. And we well exceed that on a regular basis as well. I think, again, going back to our pre-COVID numbers, it was about almost 87% of those episodes met or exceeded that. And the majority of them are responded to within 30 minutes. So it's usually much lower than that 45-minute response rate. And then when we talk about schools in particular, for our SBDI schools, on average across the 60 participating schools we have in that particular initiative, we've seen mobile crisis referrals increase by about 42% as a result of connecting through that particular program, and also decreasing court referrals by about 33% on average. So again, that connection is really an important one, and particularly, with the purpose of this call and diverting and better serving our Black and Brown youth and our BIPOC youth. We found that to be a really great relationship and connection there. And just the final thing, I guess I would just say, we've also seen lots of positive outcomes in client and referral satisfaction. So we have data we could share about that, and also reductions in symptom severity and improvements in functioning among the youth themselves.
Amazing. So many great outcomes already, just listening to Geneva and Jeana talk about their states. Smitha, I know, particularly as a young person, how has it been if you have encountered a mobile response? What is your take on it, and what are some positive outcomes that you have seen working on this issue?
Thank you. I think in my role as a program coordinator working with young people for a youth leadership organization in California called the Youth Leadership Institute, we run youth programs, but our program coordinators are allies and mentors to the students, and sometimes students feel comfortable confiding in us about things. And we had an incident where a young person reached out to me because they were concerned about their friend who had given them a suicide note. And without going into too many more of the specifics there, we were pretty poorly equipped to respond because we didn't know who to reach out to. And after I kind of reached out to my boss and he reached out to his boss, and then all of them were talking and trying to figure out what to do, the best they could come up with was to call 911. And calling 911 was the worst thing that we could have done in that situation, because that young person was not actively in the moment of attempting suicide, and they were barely in the contemplating stages and just kind of talking to and confiding in this friend. And they didn't expect this at all. What's worse is they hadn't told their parents, and their parents didn't speak English. And so when the police showed up and took the young person away, their parents were very confused, and the whole thing was a really traumatizing experience. So that kind of reveals the importance of having a mobile response that's community centered and community tailored, and that doesn't involve law enforcement. I think that if we learned anything from that situation, it's to try to engage the student a little bit longer, and then to lean on community mobile responses where they exist rather than to call 911, because those community members are better attuned to the needs of people within that community. And there is even the possibility of like folks who know specific languages being able to speak to folks in their first languages. Like that family spoke Spanish, and if we had a mobile responder from the community, from that community, who was also able to speak Spanish, then the whole miscommunication might have been resolved, and it might have reduced some of the trauma of that interaction. Not to say that there isn't, because a mental health emergency is a really challenging thing for young people and for their families, but this young person was not actively in that moment of, you know, the mental health emergency. So just recognizing the need for nuance and understanding that that nuance usually comes from within the community in which young people live, because those are the folks who better understand their experiences. I think that if I had to think about positive outcomes, I think it just alerted our organization to the need for having a mobile response and being tapped into that, because we do work with young people where we talk about substance use and mental health, and we educate young people on mental health, and it doesn't make sense for us to not be equipped to respond to those things. And part of being equipped, I would say, is for schools and for, I guess, community and local health agencies to partner with community-based organizations that work with youth. Because oftentimes those are the adult allies that they will reach out to in a moment where they're in need. And the adult allies in those programs and in those community organizations should be connected to and well-resourced, should be connected to resources. So yeah, I would just add having partnerships, strong partnerships between community-based organizations and schools or local governments that invest in training for those CBOs is really valuable.
Awesome. I appreciate that. And it's a good segue into our next question, which is, you know, first of all, like why is mobile response a good alternative to keeping young people safe than using law enforcement? But also, what is the ideal structure for a mobile response? Smitha already talked about, you know, community involvement and ensuring that community is involved in the process, and also like ensuring that people are trained enough to like be empathetic and to be able to talk to them longer. Dr. Bracey, what would you add to that?
Yeah, those are great points. Thank you, Smitha, for bringing those up. You know, you had mentioned one in terms of the appropriate sort of responses for mobile crisis, or, you know, if it's not imminent risk of harm or danger, you know, that there is an opportunity to use mobile crisis rather than emergency response systems. And, you know, again, that's one of the reasons for our system not restricting it, and, you know, really kind of letting well, you know, there's some restrictions, but, you know, having the caller define what it is that they need assistance with. And there's been, you know, there's often a misconception that it's only for risk of harm to self or others, but ours is much broader than that in perspective. And I think that lends to the safety and credibility of this program, because it is, you can, you know, start with, you know, it's kind of less scary or less intensive, or, you know, it's a lower threshold, so you can catch things earlier. You can use it somewhat preventatively as well. And so that's one of the beauties of the system, and I think one of the strong ways to kind of structure the system as well. And then by being able to just respond anywhere is another key feature. So, you know, it can be at the home, it can be at the school, it can be anywhere in the community where the need arises for that de-escalation and crisis stabilization. And of course, most recently expanded that to telehealth as well through the pandemic. And so having that separate call number, 211 instead of 911. And again, as we're moving towards the 988 system, having that being a separate entity from 911 kind of helps create that distinction and remove some of that unnecessary police response as well. And I just wanted to mention too that in response to the family issue that you had mentioned, Smitha, I think that's also really important that, in Connecticut, there's a mobile response is allowed without parent permission in that need, in the case where a crisis situation or a need for immediate response. However, of course, best practice is to engage the parent and the family and make sure that they're on board and informed and aware of what's happening to particularly to avoid the type of situation that you just mentioned, because there is a lot of stigma, a lot of fear, can be a lot of misunderstanding about what is happening when these people show up at your door. And so I think, certainly that partnership with the family is critically important, as well as the other ones that you mentioned in terms of school, having, that linkage to the school system. In our system too, we, have partner with pediatric primary care, partner with the emergency departments, so that there is that opportunity to sort of transition. And even if the police is the first responder, the police can refer to mobile crisis as well, right? So it's in our state anyway. And so I think, making sure that there's that warm handoff is really important, but also really clarifying that mobile crisis plays a really distinct role in helping to either prevent or facilitate access to higher levels of care when that is needed, but in an appropriate way that goes through, the appropriate assessment.
Geneva, do you have anything to add about ideal structures for mobile response and ways to keep young people safe in times of need?
Yes, actually, we are not, we partner with child serving agencies across the state because that's one of the basic tenets and philosophies of systems of care. But we don't have a mixed model, and Oklahoma is fairly conservative. We're very rural, and what we found is there's very much a difference in the police response by age, and so it's only when we get into kind of the teenager and the teenagers that the police response becomes a little bit more problematic. But what we've found is they are open to our systems of care staff coming in, the mobile response teams, we just call them MRTs, because they recognize that they don't have the background to deal with this. And, they're under a lot of pressure right now as well. There's a lot of national pressure. There's been state pressure. It's been more difficult in the larger cities like Oklahoma City and Tulsa. There's a lot going on and there are conflating factors. And I think that the good partnerships that have been developed help. It's also been helpful that systems of care, that this is a state effort. So it's not different counties trying to do this and this and this. The money comes from the state and from Medicaid. The state provides the training and we provide the data. E-Team, one of the things that we did as the evaluation is we built the data system so that the call center is entering data into a live website that the mobile response team, even if it's 300 miles away, they can see the data. So you're not having to ask the family to repeat themselves. It keeps the situation from escalating. We do a warm handoff. Everybody knows who's at the site. And while all of that is going on, while the MRT is going, the call center is doing what it can to de-escalate. So if the police are already called, they're calling the police. They're making sure that we're reaching out and we're de-escalating, not just with the youth and the family, but with the partners are there. We do that. So a lot of times, law enforcement is already at the site. It's not that, they're already there. DHS will already be there. And even sometimes emergency medical services, ambulances will already be there, especially in rural Oklahoma and probably rural counties everywhere. People aren't sure who to call sometimes, right? And they're like, just call, I'll call anybody. And it is that 911 thing. And so one of the things that we found most helpful is there's a separate 800 number. It's a toll-free number for the call center. It's a statewide number. You only have to call one number and you can get help anywhere in the state. And DMH has done a pretty good job of making sure that they got that information out to police departments and DHS offices, hospitals and clinics, private therapists, schools. I mean, a lot of it's about making sure that there's easy access to the information.
Yeah, awesome. And I think like that's a very valid point about like right now, law enforcement is still involved and very much so the only, system that many people know to call. And so how do we kind of still, like people are still using them. And so how do we get people to move away from using law enforcement as the first line of defense to kind of answer these mobile crisis calls? And I think Dr. Bracey talked about it with the 988. As we start to implement 988 across the country, people will know there is a different number and a different access point to mental health supports. And then there's also, Smitha talked about a community building and ensuring that people are aware of what's happening in their community, are in touch with each other, are connected in that way so that they can have those resources on hand. And I think, as we think about, I think as this process happens, as we start to implement, as we try to move away from co-responder models, there will be times when people still call the police. And my question, I guess, Smitha, I want to know what you think about how are some ways that we can actually get people to, move away from calling the police versus what do you think are some effective ways to get people from using law enforcement and using 988 as a way to get services?
This is where it gets tricky because the way that we approach mental health as a whole system, it operates on all levels. It operates in the school, it operates in the community, it operates based on stigma we have around mental health, and it operates based on biases that people have. So when we talk about police calling 911 for a mental health emergency, people calling 911, I think that part of it is information, right? Part of it is raising awareness about 988 and explicitly branding it as a mental health emergency, and also pairing it with education of what is a mental health emergency so people can recognize the signs. Because a lot of people still don't know what a mental health emergency looks like and will call 911 for any emergency. So there needs to be a lot of explicit education kind of reinforcing the difference, and that starts at the K-12 level up. So not just in workplaces, it has to be like widely known. The same way we teach kids to call 911 from a young age, we have to teach kids and everybody to call 988 for a mental health emergency and recognize the signs of what that is. And furthermore, I think that there's still the reality that people will call 911 for what they don't understand to be a mental health emergency, or because they feel threatened and don't even get that far in the inquiry. Because we'll often see a lot of young people of color will have, let's say, like an epileptic attack or a seizure of some kind. And because it is in public and other people are threatened because of their own biases, they'll call 911. And that is still a possibility, even with all the education about the 988 response. And so I think that, like folks have mentioned, like Dr. Bracey and Geneva Strech have mentioned, like having there be enough collaboration between law enforcement and like 911 hotline operators specifically, and the 988. And I think one way to do that would be to have kind of a script of, questions to assess whether it's a mental health emergency or not, because sometimes people will mistakenly call the hotline, like the 911 hotline, and then it's the operator's role to determine whether or not that is a call for law enforcement. And oftentimes they don't, because they will respond to almost all calls because maybe, I don't know, they anticipate that there's something more going on, or they want coverage, whatever that is. It's hard to predict whether police will want to give up their jurisdiction in a situation like that, because they may still feel that there's a need to respond. But I think in those situations, maybe having cops be trained for it to be a both and, so that they're bringing along a mental health responder with them and allowing that responder, who is probably better equipped and trained, to assess the situation. But that's not always possible. Sometimes they just want to get someone out there. So in that, like,
Oh,
the
sorry.
training, I was just going to finish just that the training would be helpful for law enforcement in those situations. But yes, go ahead. Yeah.
Yeah, and I think hold on one second, Geneva. And I think what we emphasize, while we're emphasizing no co-responder models at all, and realizing that police still exist as they do now, and they may show up. Going to your point of training, right now, police are being trained in crisis intervention training, which is this training that they can choose to take or not. But we recommend, and kind of to Geneva's point earlier, is like knowing when to do a handoff. So if they do arrive, knowing when to like leave the scene to assess to know how to assess a crisis, and when it's a mental health crisis, to call the right people in place. And we believe that one of the ways to do that is not through just CIT, but through mental health first aid training. A lot of people are not familiar with it or have not taken it, but we think it would be very beneficial to police and law enforcement if they are the first people on the scene, so that they know when to hand off a call to the right providers and mental health professionals, so that we will avoid causal and even fatal interactions with the law enforcement. And so that is one way. So thank you for including that training. And Geneva, you were going to say something?
Well, I just wanted to say that we talk about training like that a lot, and we talk about training people not to call 911. But the reality of the situation is people get trained in all kinds of things. It's a one and done, they forget them. When the police are there, if the call center, when the caregiver or the MRT, when they're on the phone with the call center, if we can get the call center on the phone with the police, it de-escalates the situation for them too, right? You lower their threat level, you kind of get them to, you tell them help's on the way for you, in dealing with the situation. And they tend to have an emotional response where they remember, and it makes them more open next time it happens. But it can't happen in this kind of training situation because it just doesn't stick. I mean, how many times have we seen that? It just doesn't stick. And so I think part of the training is that when you get police out there, if you are working, once you have an 800 number or the 988 number, if you can get the mobile response team or the call center while you're waiting for the MRT to get there, get them on the phone with the police, so that the police are getting technical assistance about what to do in this situation. And they understand that there's another agency involved, right? There's going to be more oversight. There's technical assistance in helping them de-escalate the situation. A lot of people, this is what we found when we did key informant interviews, a lot of people really do feel threatened when someone else is having a mental health crisis, right? We have to insert ourselves into that. And so you have to deal with that to get people to take a step back. And I mean, I am an educator, but it seems particularly ineffective in this situation. And so I think that training is good, but we need strategies for in the moment and when it happens. And we need to take that as a teaching moment and make sure that at every opportunity, because you convince a cop one time, next time he'll call you.
And Dr. Bracey, before you jump in, I just want to also ask you to add in, I know Connecticut has a good system and really using 211 as their point of entry for access to mobile response. Can you also add in, because one of the things Smitha suggested was that, making people aware of 988. How did you get the whole state of Connecticut to kind of join this bandwagon of 211? And what are some ways that people can do that with 988?
Yeah, those are great questions. And I guess I first won't pretend that everybody's totally on the bandwagon and that we're, there's still a lot of work to be done. We, as much as the utilization has increased and awareness has increased, it has been a long road over, more than 10 years, over 12 years of doing this. And it's still underutilized. I mean, there are still many opportunities where mobile crisis could be called and utilized where it's not. And so a couple of things. One is, one that I actually wanted to sort of piggyback off of what they were just saying is a policy component, which is memorandums of agreement between schools and the mobile crisis providers. So that actually came through legislation in Public Act 13178 back in 2013, following the Sandy Hook tragedy in our state, as a response to kind of improving our statewide behavioral health system and creating a statewide plan for behavioral health, children's behavioral health system reform. And one component of that was integrated in was that all schools would have a memorandum of agreement with their mobile crisis provider, kind of stating what the roles and responsibilities are during a response, and when to utilize, when to call them, what the responsibility is once they get there, and what are the responsibilities on the school side for determining what's appropriate and when to utilize the system. And so we have, I believe we are just shy of like 3 maybe districts that haven't fully completed that agreement, but by and large, I mean, the vast majority, almost 100% of our school districts have an active agreement with their mobile crisis provider. And so that's one step that it at least starts the conversation. And of course, the implementation is only as good as, as you have to move on, you have to do those training things that you mentioned, and you have to actually implement it. But that has been one really big step in promoting awareness around the mobile crisis system. I think another one is that our mobile crisis providers, as part of their contracts, are required to do outreach presentations. And so they have a set number of outreach presentations that they do to schools and communities on a monthly basis. And so that helps with it as well. And then there's been an ongoing large-scale, full-scale public awareness campaign around our mobile crisis program. So everything from bus ads, from TV, PSAs, public service announcements, posters, handouts, magnets. We've got water bottles, backpacks. I mean, there's everything. They've branded everything about 211 and calling that, and that also aligned with our suicide prevention, statewide suicide prevention work as well. And so between, I think all of those efforts have kind of, integrated to help kind of promote that. And certainly some lessons learned that could be used moving forward, thinking about 988. Again, having that one single number is really critical. And that branding and just getting it out there everywhere you see. I mean, you can drive down the highway and see it on a billboard. You can see it on a bus stop. You can here in Connecticut, it is kind of everywhere, and which in some ways normalizes it, right? Because you see it, it's familiar, and it's accessible.
Awesome. So we're slowly running out of time, so we're going to ask the one last question, and there's so many questions coming in from the audience, so we're just going to take some time to answer the last question that I had for you all, and then we'll go to the audience. And that is, what is, in states now, they're starting to roll out 988. There's many states that's passing legislation for 988, and including that with mobile response. What's some implementation advice you want to give states and localities that's starting to do this work to have a safe and effective mobile response for young people of color specifically? And we can start with you, Smith.
I'm sorry, can you repeat the question just one more time?
What as states start to implement and start to use 988 and start to make legislation around 988, including mobile response, what's some advice you want to give them about implementation to have a safe and effective mobile response model?
Definitely. I think that the main goal of a mobile response model, especially a mental health mobile response model, is coverage. And the reality is we don't have as much coverage for mental health response as we do for 911, just because of the relative scarcity of people who are trained in mental health mobile response. So I think that I guess on the local level, it is really important for cities to build capacity and to fund and maintain a standby unit of people who are paid to do that. The same way that police are paid in their roles, because without funding, you can't ensure that you have a base of responders on standby. And I think that it's also helpful for those folks as kind of the core or the nucleus of the community mental health response to be connected with and be able to tap into like folks who may be trained and on standby, who are not part of the immediate response, but may need to be deployed, so to speak, if there's like a young person in their community or in their area who's having a crisis, and then they're trained and they're able to go. And it's also helpful if those community mental health response units make sure that they have capacity in terms of language for kind of at least the main languages that are spoken in that community. I think that that's a minimum. Also, I guess to an earlier point, I know that states are often kind of unrolling their mental health mobile response on a state-by-state basis. And it's, I guess, really important for the 988 number to be marketed nationally and really consistently, the way that Dr. Bracey described the marketing of the 211 number. Because if people are not aware of it, they can't use it. And as long as people are not aware of it, 911 will continue to field these responses, and it'll actually slow down the transition to the 988 model. So I would just say having a really, really strong awareness campaign is important. And I would even do paid ads on TV or on the radio if that's what it takes.
Awesome. We're slowly running out of time, so I want to make sure we get to the audience questions, and I think you all will be able to answer that question through some of these questions that the audience have asked. So I'll start with you, Geneva, because you talked about the rural area and like, you know, the complications with what they have access to. So I'll let you start off answering this question. The question is, how do we approach small town conservative law enforcement to divert emergency calls to a non-police dispatch, or find out if our state is developing a separate digital 3-digit crisis response number?
Well, I don't know about the 3-digit crisis response number. Like I said, the Oklahoma Department of Mental Health set up a separate contract for our call center, specifically for children's mobile response, crisis and mobile response. But the local law enforcement, because we came in through Oklahoma Systems of Care, and there are community partnerships required through Oklahoma Systems of Care, or well, for Systems of Care requires child serving agencies. So those partnerships have been in place for a while. Especially in any kind of rural community, it's who you know what I mean? And so people are going down and saying, hey, we got money from the state, look, call this number. We're going to be able to do crisis and mobile response. If you have a need, you just call and help us get this out. I mean, we actually have our partners helping us disseminate information. We also did TV spots. We did put things up on buses. We had a social media campaign. And we also sent information to all of the partner agencies. Look, we can help you. Are you struggling? We can help you. And here's the number. And so I think trying to get information to the public and trying to train them on how to recognize that. And that's very important, but it's also as important to make sure that you're taking care of that from the professional side, because I mean, really, sometimes those are the ones that can do the most harm in these situations. You know what I mean? And so we gotta balance that. And that's what I would say in rural America. You got to go visit. You got to get face to face. Yeah. And you got to tell them. You got to convince them what it's going to do for them.
Yeah, and that makes sense. So the next question we have, thank you, Geneva. The next question we have for you, Dr. Bracey, is how can we destigmatize or uncouple this idea that people who are experiencing mental health emergencies are inherently dangerous or violent?
Yeah, that's a tough one. Very important, of course. And I think that's partly why having it broadened in terms of what our mobile crisis can respond to is you don't have to make that distinction as the caller, and you don't have to be the clinician and to assess the risk yourself. If there's any concern about someone, the best way to intervene or prevent that is to do it early, right? And so I think that's one way in terms of sort of breaking down that stigma. But again, it does really go back to the relationships and just the information sharing, right? And I think it's some of the work, again, with our school-based diversion initiative. We know that there's significant overlap between youth with juvenile justice involvement and youth with behavioral health needs, and not necessarily because there is that they're danger, but because the behavioral challenges a lot of times are misunderstood or misinterpreted or mislabeled and not intervened with appropriately. And so again, I think it is a lot of it goes into that process. One of the things I wanted to mention that had come up in the chat also, particularly around law enforcement engagement, is we also have memorandums of agreement with the law enforcement agencies and the schools. So again, thinking about that particular relationship and clarifying when is it a school, when is a school policy or violation versus when is it a discipline issue versus when is behavioral health versus when is it a law enforcement matter. And so really getting clear and distinguishing between those things and putting in supports for staff and responders to be able to de-escalate a situation in the moment. As Geneva mentioned, when you're scared yourself or uncertain, or you're having your own trauma response, or you are dysregulated in whatever way, it can be really difficult to kind of put that training and those thoughts into motion in the moment. And so really kind of proactively providing supports around that is really important.
Thank you so much. So we have about 2 minutes left on this webinar. I just want to take some time out to thank all of our panelists for joining this call today. And I'm going to turn it over to, and if we didn't get to your question, I'm sorry, we have their contact information up and I'll put it in the chat and you can reach out to any of us, but I'm going to turn it over to my colleague, Isha, to close us out.
Hi everyone, I'm Isha Wersingham, Senior Policy Analyst and work with Whitney on the youth team. I also want to echo our thanks to Smitha, Dr. Bracey, and Geneva for joining us today. And if you have a question that wasn't answered, please reach out to Whitney. I'm going to put you on the spot, but to Whitney, and we can also if you want to connect with any of our panelists as well, we're happy to connect you. So we hope that this is the beginning of the dialogue that we would like to have about this issue. And we look forward to connecting with you in the future. Thanks so much.
You're muted, Whitney.
I was just saying, thank you all so much.